Thank you, Carlos, for the introduction. Good morning, everyone. This is my disclosure slide relevant to this talk. So this is actually a change, a different perspective. And what you've heard so far from Stefan and from Alan is about the sensations of bladder fullness and urgency, which reflect changes in the physiology and the pathophysiology of what's happening in the lower urinary tract. But of course, it's not just the changes that occur, but it's the central processing of these afferent signals which results in the perception of these signals. And it's not just the sensation of a compelling desire of a need to urinate, but it's the emotional color that's attached to that, the emotional interpretation of these afferent signals from the lower urinary tract. We know that often that the response to treatments that are commonly used for the overactive bladder, such as with antimuscarinics or tubular stimulation, do not often correlate with changes in urodynamic parameters. We also know that the psychological state of the individual can influence the perception of bladder sensations as well as urgency. And there are studies that have clearly shown that individuals who have anxiety and depression, there are alterations in how they perceive their sensations of bladder fullness. And of course, all of you are aware about treatments that are cognitive-based, where the treatment is addressed at the level of the brain and not of the bladder, which result in successful outcomes for overactive bladder symptoms such as bladder retraining and distraction. So clearly, the central processing is quite important in the perception of urinary urgency. Now, what are the tools that are available to study the changes in the brain? And essentially, in the modern era, this is brain imaging. So it first started out, of course, with studies with SPECT. So this is just one study, and so in the last 20 years, just looking at changes in the brain in healthy controls of who urinated. And quickly, studies moved on to use another tool, which is PET. And essentially, all the studies that look at functional brain imaging use two different types of paradigms, essentially. One that involves repetitive sort of pelvic floor muscle contractions on full and empty bladder, and the other using a catheter with alternating bladder filling and emptying. And what's looked at is the changes in the cortex and the subcortical structures during the micturition cycle. Now, currently, most studies that look at the changes in the brain related to the lower urinary tract adopt functional MRI, essentially because it's a non-invasive technique, it's radiation-free in contrast to PET, and also it's a better time resolution. And essentially what we're seeing when you see the colorful maps that appear are essentially changes in blood flow. So when there is some neuronal activity, there are changes in the blood flow. There's an alteration in the ratio of oxygenated hemoglobin and deoxygenated hemoglobin, which is known as a Bold effect. And it's that contrast that we're seeing in these images. Now, there are a few centers in the world that have been looking at using brain imaging, but most of the studies that I'll be quoting in the subsequent slides are from the Pittsburgh group, led by Derek Griffith. And essentially, what happens is when the bladder is infused and when there's a withdrawal of the fluid, is that there are changes in brain activity, and these changes tend to correlate with the infusion and withdrawal, and the peaks in activity tend to correlate with infusion, and the difference between infusion and withdrawal is a contrast that we look at. And this is on a voxel basis, and when all the voxels are then analyzed and mapped onto a 3D map of the brain, and when statistical tests are used to compare between states, what one gets is therefore a map of the brain, which shows areas of significant change in activity between infusion and the withdrawal state. And these are the bases of the maps that you'll be seeing in the subsequent slides. So moving on, and as Stefan started out with, I will also start out with healthy controls. So what are the changes that are seen in brain activity with bladder filling? So in individuals who have good bladder control, when their bladders are infused with small volumes and what they perceive as mild sensations, you get particular areas of the brain that light up. specifically the insula, which plays an important role in visceral interoception, and the anterior cingulate gyrus, the periaqueductal gray, which is thought to be the first point of relay of afferent signals from the brain. From the bladder, sorry. Now, what happens when it's the same group of people who are healthy controls, who have good bladder control, but now it's a large volume of the bladder that's infused, and they perceive a strong desire to void? As you can see, there are changes in the brain, and what you see is especially the areas such as the anterior cingulate gyrus becomes more prominent. The activation, the insula becomes a bit more prominent as well, and it moves anteriorly, which correlates with this sensation of unpleasantness that's associated with a full bladder. Now we move on to patients who have poor bladder control. So individuals who is the basis of this roundtable, who have urinary urgency and have proven detrusor overactivity in urodynamics. And so you start out with a small volume infusion. These group of patients, when they report mild sensations, what you find is, in contrast to the picture that you saw previously, is that you see a weaker response and a much more patchy response. So for example, the anterior cingulate, for example, and the insula, you find that there's a weaker response, which might reflect a poor compensatory change in this group of individuals. And also what's seen is, in the same group, is that there's a prominent what we call deactivation, which means that the activity is more in the withdrawal state compared to the infused state. So the reverse of what you see in the red is this area in the green, and especially in areas of the limbic circuit. Now, same group, but this time now a large volume is infused. With large volumes in the bladder, there's a strong desire void reported by these patients. And what you see is in contrast to the weaker response, is quite an exaggerated response. And you see red all over, with prominent activation of the anterior cingulate gyrus, prominent activation of the insula, and in the brainstem, the involvement extends, in the posterior fossa, extends beyond the brainstem to areas of the cerebellum as well. So an exaggerated response, which is quite distinct from what you saw before. And individuals who have a detrusor overactivity whilst in the scanner, you find that there's areas of prominent deactivation, the areas in green, in the areas of the brain that are the frontal lobe, specifically what we call the prefrontal cortex. There's also deactivation in the medial part of the temporal lobe that we call the parahippocampal gyrus and the amygdala as well. And additionally, also, what you find is areas, what we call the supplemental motor area, are also showing areas of activation. And this is a part of the area that's involved in pelvic floor muscle control. And so it possibly might represent an attempt by the individual to use their pelvic floor, the urethral sphincters, in an attempt, a desperate attempt to maintain continence. So what emerges is that there are some patterns that might be there. I think this is probably a gross oversimplification of the complexity of these studies. But it does seem that in individuals who report urgency, that there is quite prominent activation of the anterior cingulate, which makes sense in the sense that the anterior cingulate is part of the limbic cortex, which is involved in emotions and the interpretation and the perception of emotions. What's also seen is that there are certain parts that consistently become deactivated, which is the prefrontal cortex. And what's known as the medial prefrontal cortex is an important structure involved in decision-making in tasks that have an emotional flavor to them. And so some patterns do tend to emerge from these studies. Now, is there any study that's looked at an intervention? And once again, we go back to the same group. And I won't go through the details of the study, but essentially, this is a group of elderly women with urgent continence who were undergoing pelvic floor muscle training. And what the investigators did was to image the brains before and after the pelvic floor muscle training. And I won't take you through the results, but what I would like to point to, and it's what's quite apparent even to the untrained eye, is that in individuals who ultimately were responders to the treatment, in contrast to individuals who were non-responders to the treatment, there are distinct patterns of brain activity even at the baseline. which I think is quite significant and seems to suggest that there are perhaps two groups of individuals out there with urinary urgency, and possibly in the future, could a tool like functional brain imaging be used as an imaging biomarker to identify patients who might possibly respond to a particular treatment. But before we sort of draw any conclusions, what I would like to, however, emphasize, and the important message that must go out, is that these changes that you see in the brain in someone who has urgency, really, we don't know what it represents. We know that there's changes in neuronal activity. What we're seeing is changes in blood flow and changes in ratios of oxygenation. But actually, what does it represent to the patient who has urinary urgency? So there are many possibilities, and I must say it's something that we clearly don't understand. We do know that whenever there is when the bladder is being filled, the stretch of the bladder, the mechanoreceptors are actively discharging. And of course, could some of this represent the afferent volley from these mechanoreceptors? These are patients who tell you about a sudden compelling desire to pass urine, and could these changes represent that sort of a state where the patient has urgency? Could it be the emotional content that's which is attached to urgency, that fear of leakage that Alan took you through, the anxiety that's associated when someone becomes urgent, or perhaps the apprehension, will I become incontinent? Will I be entering an embarrassing situation? For example, right now, if I become incontinent, there's an apprehension about the embarrassment associated with that. Could some of these changes be representing that? Could some of these changes be representing compensatory changes? For example, someone who is urgent and who has become incontinent has learned that by squeezing their pelvic floor muscles, for example, that they might be able to avoid becoming incontinent. So the changes that you saw in the supplemental motor area could possibly be reflecting that. Something that isn't studied in the artificial environment of the scanner is what happens in real life. So if someone becomes urgent in a situation that is a socially acceptable time and place to void, for example, in the safe confines in their home, or when they can see that the toilet is nearby, their response, one would expect, would be different from someone who becomes urgent in an environment that is probably socially inappropriate and socially unacceptable for voiding. Something that couldn't be looked at when in the current brain imaging studies. Now, so far we've been talking about consequences, but could it be the cause? Could it be what we're seeing here represent the primary brain pathology? So most of your patients who come to you with an overactive bladder, if we think it's a neurological cause, often would have a structural lesion that can be seen, an infarct if it's white matter disease, or changes of Parkinson's that represent the structural basis for the overactive bladder symptoms. But there is a larger group of patients who come to you with overactive bladder symptoms where we don't know the cause, the patient has been extensively investigated urologically and neurologically, no cause is found, and we use the term idiopathic. But could it be that rather than structural changes, that there are functional changes in the brain in this group of patients? In which case, could this be the primary brain pathology? And we don't know the answers. So what we find is some wonderful brain maps, but we just don't know exactly what it represents. And in that case, it does question whether this can ever be used as an imaging biomarker for urgency. So in conclusion, to answer the question, is there a brain map for urgency? I think what emerges is that there's likely to be some distinct patterns of brain activity in patients with urgency. This probably reflects altered central processing of signals from the bladder. And what is clear is that even at low volumes of filling, in patients who have an overactive bladder, there's clearly changes in brain activity which are distinct from individuals, from healthy controls. However, it's not clear what these changes represent. And what's really needed is more studies, more people interested in the field, because clearly this is a potentially attractive imaging biomarker. But what is also needed is a move from the bench to the bedside, and something that's more convenient, something that can be practically used in the clinical setting. And this is where evaluating other techniques such as NIRS, for example, which can be used in the neurodynamic suite, or even other imaging modalities like EEG might possibly play a role. Thank you very much.